All right, guys, welcome back. Today or tonight, whenever you're watching this, today, whatever, we're going to be talking about the knee joint. We're going to cover the knee joint, and I know you've heard me say this a lot, but I truly enjoy the knee. When I was in high school, when I was a junior in high school, I blew out my ACL, partially tore my MCL, and partially tore my medial meniscus, and it's kind of what's gotten me down my journey of my profession and my career. So I owe a lot to the knee joint as I see it, and it seems like it is just a simple hinge joint, but there's so many little intricacies, and there's such a balance, lateral to medial and anterior posterior, that it really is kind of, as you'll see and as you'll get to experience and appreciate, there's a lot that goes into it. Okay, there's four main ligaments that provide the stability, but there's also kind of a whole slew of muscles and positioning, and then we'll talk about Q angle and all those different things that are now going to draw forces or affect the knee in different ways. So there's 82 slides, and a lot of the muscles you're going to hear again, a lot of the femur landmarks you're going to hear again. So we're going to kind of go through those pretty quickly. So hopefully this isn't as long as the hip. The hip was pretty long, but we're going to get through it. So here we go. All right. So let's see. There we go. All right. So just a kind of generic description of it. The knee is the articulation between the femur and the tibia, right? We all know that. You have the two condyles, the medial and lateral condyle articulating with the medial and lateral tibial plateau. You have a patella there in the middle, and we'll get to the role of the patella. There's kind of two main roles. Okay, you can see here the clear depiction of four different ligaments. Your collaterals on the side. Yep. And then your cruciate ligaments on the inside. Okay, this depiction also clearly shows the meniscus, your medial and lateral meniscus, and then we'll talk about those two different things there as well. Okay, we'll end up lecture with looking at some injuries that are pretty cool with the knee. Okay. So, one of the more complex joints in the body, like I said just a second ago, you wouldn't think that it is. You would think that it's just a simple hinge joint, but there's lots of different intricacies that we're going to go through. Okay, supported and maintained entirely by muscles and ligaments with no bony stability. It says no bony stability. There is some bony stability, but it's not a lot. It's kind of like, you know how the shoulder was like a tea dish, and kind of that humeral head was sloshing around on the inside. It's kind of like how the knee is, right? The tibial plateau is kind of, I mean, it has kind of a concave shape to it, but those femur condyles can still slosh around in there pretty good. Okay, it is one of the most frequently injured joints of the body. It is usually exposed to severe stresses and strains. Okay, and we'll talk about the importance of the closed pack and open pack positions and why those are also important with the stresses and strains. It is one of the largest joints in the body, so yeah, there's a lot that goes into it, and I think that it's pretty surprising to people, especially kind of the general public. When you have a patient and you start talking about the different aspects of the knee, most people are completely shocked that the knee has this many things going on. And I think that's what also leads the general public to go into these total knee replacements and think that it's just no big deal, and think that they're just gonna spring out of these total knee replacements. I think in our society we downplay our total knees because they're just so common, like I've told you guys before. But especially with the knee, I mean, the knee is everyone. Like I said, everyone just sees the knee as just like a hinge, like a door hinge, right? But there's so many different intricacies that total knee replacement now has to coordinate and has to supplement. That there's so many different things that can go wrong, and the fit has to be perfect and everything else. So when people say like, "Oh, I just had a total knee," I don't think it gives the credit to what the total knee is. Okay? And you'll see that once you start getting onto the clinics. People be like, "Oh, I just had a total hip," it was only a total hip or it was only a total knee. Those are still major orthopedic procedures. So the joint structure, it is classified as a synovial hinge joint. However, it is not a true hinge joint. There is a rotational component where that accessory motion that accompanies flexion and extension. So what that not true hinge joint means, the true hinge joint would mean, let's see if I have a napkin here on my thing, on my table that I'm doing lecture from because we're in isolation. Okay, true hinge joint would be if this stayed still and that just opened and closed. Okay, but that's not the structure that we're dealing with. Okay, if this was a structure that we deal with, it would be our life would be a lot easier. Okay, the structure that we're dealing with has those arthrokinematics in here. Okay, it has the roll and the glide in different directions because otherwise it would just roll out of socket. You've heard me say that before with the shoulder. Okay, or we could also draw it. Okay, so again, I'm going to try and do this as best as I can. I hope that we are in the picture. Okay, but if we draw it like we are in like 15 degrees of flexion. Okay, I think that's fair. Uh-oh. Let's see. Okay. We'll say just for our sake that rotation, center of rotation, may be there. Okay. But if we go into more 90 degrees of flexion, okay, that center of rotation now may be there. So as we go, okay, so as we go from extension into flexion, that previous center of rotation, okay, that previous center of rotation is now going to kind of move in an arc. Okay, and that is the reason, or that is the result, I should say, of that roll and the glide. Right? Because like I said, if we had just a strict hinge joint, we would roll right out of its articulation. Right? And that wouldn't be good. Right? So we need to have the roll and the glide in opposite directions. Nope, same directions. Okay? So that if it's an open kinetic chain, because it's a cave structure moving on a convex structure, right? It's going to have to change in order to stay centered in the joint. So joint motions, we have flexion, extension, okay? Really the only two. We'll get to the spin here in a second, okay? But our main joint motions are flexion, extension. We characterize it as 0 degrees of extension all the way out to 120, 135 degrees of flexion. If you would write over here, depends on size of limb or soft tissue approximation, okay? Your string beans, okay, they're going to get more to the 135, possibly even 140, okay? Your bigger people, okay, they're with a little bit more tissue approximation, they may only get to the 120, 125, okay? After total knees, our goal is 0 degrees of extension so they don't walk with a limp, all the way out to upwards of at least 120 degrees of flexion, because that's what we characterize as functional. Okay? Going up and down stairs, bending over to tie your shoes, sitting down in a chair, you need about 120 degrees of flexion in order to be true functional. Okay? So those are kind of the two magic numbers after knee rehab that most people are worried about getting. Okay? All three arthrokinetic motions are present. Okay? We have a convex femoral condyle, moves on the concave tibial condyles in a, which one? In a closed kinetic chain. We have a concave tibial condyles moving on a convex femoral condyles in an open kinetic chain. Okay? So if the femur is moving and the tibia is staying the same, it's closed. The femur must glide posterior on the tibia as it rolls into extension. Okay? Their book says that weird. Go back to your arthrokinematics and think about how it is. Okay, if we talk about a extension in a open kinetic chain, let's talk about it really quick. High-tech eraser, yes, that's how we roll. Yes, this is my kid's art easel. Again, that's how we roll. Okay, so I'm going to draw the femur in a sagittal view. And then as we go into extension, hold on. As we go into extension, whoop, you can't see that. There we go. Okay. As we go into extension, you're going to have an anterior roll and an anterior glide. Okay. I know that third bullet says the femur must glide posteriorly on the tibia as it rolls into extension. Okay. That is saying that if we draw this differently, now if we have a closed kinetic chain where our tibia is vertical, okay, and our femur now comes, okay. Now as this is going in a anterior roll, okay, we must also have that posterior glide. Okay. So it just depends on what you are talking about moving. Okay. With that example, there's a convex moving on a concave, so they're in opposites. Okay. So I know that third bullet's confusing. It just depends on what you are talking about moving. Okay, if you're talking about open kinetic chain, it's a concave moving on a convex. If it is a closed kinetic chain, it is a convex moving on a concave. Okay. So the medial femoral condyle glides posterior during the last few degrees of weight bearing. This causes the femur to spin medially on the tibia, and that, my friends, is called the screw home mechanism. Okay. Screw home mechanism is when the medial femoral condyle glides posteriorly on within the last few degrees of weight bearing extension. So if you were to stand up, pull up your shorts, go into about 15 degrees of flexion. Okay. Watch your femoral condyles and go into extension. All the way into extension, you should see that medial femoral condyle kind of bloop, rotate backwards. That gives us stability in extension. Okay. In weight bearing position, the femur rotates medial on the tibia as the knee moves into the last few degrees of extension. Okay. In non-weight bearing, the tibia rotates laterally on the femur. Okay. This was what allows us to quote unquote lock our knees out. Okay. This is the full close pack position. Okay. You have that screw home mechanism activated. The knee is fully extended. We have the rotation, depending on which one it is. Okay. We are maximally congruent, right? That closed pack position, dangerous position for the knee to be in. Right? For flexion to occur, the knee must be unlocked by laterally rotating the femur on the tibia or vice versa. Okay, I believe it is the plantaris that is responsible for that. We're not really going to talk about it though. I don't know why. And this is just you can see the medial condyle, how it's a little bit bigger. It's going to rotate on a fixed tibia. If you have questions, write it down. We'll talk about it in lab. Okay, we have 2 days to talk about the knee. We have 2 days to finish up the rest of hip and complete all of knee. So we should have plenty of time to get through the knee and move on to the ankle next week. Okay. The next one, the best ones that I love, because you're going to deal with this, or you're going to treat this. I shouldn't say deal with it. You're going to treat this a whole heck of a lot during your career, is your patellofemoral joint. Okay? And that's the articulation between the femur and the patella, not a weight-bearing bone, okay? Not a weight-bearing surface. The smooth posterior surface of the patella glides over the patellar surface of the femur. Okay? Both articular cartilages. Okay? Its function is increasing the mechanical advantage of the quadriceps as well as protecting the knee. Okay? So in your book goes into increasing subpatellar compressive forces during deep knee bends. Part of the Marines, their physical capacity test, and I would ask Tevin, and I may ask Tevin or Sebastian about this tomorrow. When you go into deep weighted knee bends, you are actually increasing the subpatellar compressive forces. It's like you're taking those two surfaces and kind of grinding them up. Okay? That's another reason why a lot of people in our profession aren't big fans of seated knee extensions, because in seated knee extensions, you start with the knees back almost 110, 112 degrees, 15 degrees, and then you ask the quadriceps to pull 120 pounds up, or whatever weight you're on the stack, okay? And you're kind of trying to extend that knee, so especially around 60 to 90 degrees, okay, that subpatellar compressive forces are its greatest. So you're loading that patella, you're loading that posterior patellar surface so much that you're almost degrading it as you're going through that range of motion. Okay? This is one of the most worn out areas. So if you talk to people who have kind of knee pain, sometimes they'll describe the pain as kind of right up there at the front of the knee, and that's kind of characteristic of the patellofemoral joint. Okay? If they do a lot of squats, or if they were in the Marines, or if they were a service member, okay, they're probably going to have a little bit of degeneration behind that knee. Okay, I have it, and if you have crepitus, or if you can feel your patella, so put your palm on top of your patella and kick that knee out, okay, you can probably feel some grinding. I know I feel grinding. Okay, that's crepitus. That's that degeneration of the articular cartilage on the underneath side of that patella. Okay, and then when we get towards the end, when we talk about pathologies, we'll talk about the patellofemoral pain syndrome. Okay, and that's a tracking issue. Also, I'll probably plug that in, and I'll talk about that during the Q angle, because that's a great representation of it. But anyway, that is the patellofemoral joint. Okay? Articulation between the posterior side of the patella and the anterior surface of the condyles of the femur. And we talked about its two main jobs is to increase the moment arm. Okay? So if you looked at the difference between these two pictures, and we go back to our introductory course material, it's a circle, it all goes around, it's all connected. Okay? And you go back, right? That moment arm, that lever arm, is longer with the patella than without the patella. So what is that doing? It is giving a better mechanical advantage, because it is lengthening that lever arm, or as your book calls it, the moment arm. Okay? The other thing that it does that we've talked about before is look at that now difference in the angle of pull. Okay? This angle pull without the patella is just increasing the compressive forces between the tibia in the femur. Okay? With the patella, it's now increasing that angle and giving it a more functional line of pull. Okay? Hope you see that. All right. Ooh, that was predating myself. I thought Q angle didn't come up till later. All right. So Q angle, this is also known as a patellofemoral angle. This is the angle between the quadriceps muscle and the patellar tendon. So you do it by drawing a line from the ASIS to the midpoint of the patella and from the tibial tuberosity to the midpoint of the patella. This will make better sense on the following slide. Okay. So during knee extension or at full knee extension, normal people, okay, between 13 and 19 degrees is going to be greater in females. Now, why is it going to be greater in females? We talked about it when we talked about the pelvis. Okay, so we have to go back 2 lectures to when we talked about the pelvis. Okay? In males, right, we have a more narrow, deeper pelvis. Okay? In females, we have a wider. Now, I'm accentuating this. Yes, I know. I'm exaggerating. But you get the point. Okay? Now, what this now does is because our feet are going to stay about 4 to 6 inches apart. Hope that's in screen. Okay? So with males, our femurs can come out. We can go down, knee, tibia, foot. Okay? Femur out, down, knee, tibia, foot. Okay? What happens in females, okay, is that those femurs come out and then they have to make an abrupt change to come down and meet the feet. Now, there's lots of other things that come into play, and this isn't the only factor, but this is one of the main factors. Okay, so now we talk about patellofemoral pain syndrome. Okay, now let's imagine, okay, that our quadriceps muscle, right? Our quadriceps muscle. We'll see if I can use the red. If it's not totally dead. Okay. Quadriceps muscle comes from our ASIS all the way down to the knee. Right? Pulls pretty much on a straight line. Okay. On the females, now it's going to now pull on a opposite line, not on a straight vertical line, but on a different line. Okay, and that is what we're looking at there. Okay? Is that kneecap is now going to be pulled in a lateral direction. Okay? Whereas with here, that kneecap is just strictly pulled vertical. That lateral tracking of that kneecap is going to result in an overuse. Not an overuse. A quicker degeneration. A more acute pain issue. Okay? Because instead of gliding, and now in the center of the condyles, okay, now you have the patella now tracking over the lateral condyle. And it's just grinding away. It's just now instead of all that surface area being used for compressive forces, now it's just a very small bit of the backside of that patella that is now being forced upon. Okay, so you have adolescent females who are growing, and as we talked about in 140, they're not really as strong as they typically need to be for their body size. Remember, females peak muscle strength before their body mass peaks. So you have weakness, theoretic weakness, Okay, it's not the same with everybody. Okay, you have theoretic weakness, plus you have a tracking issue. So now the mechanics of that knee are just all messed up, and you start having pain on the back side of that patella. Okay? Patellofemoral pain syndrome. And again, this right here is your Q angle. Okay? And we may draw this on ourselves in lab. It's really difficult to draw on yourself. It's better if you draw it on a partner. But imagine that this is a little bit wider, and that angle of pull, that line of pull, is going to be coming more from this outside. And it's going to pull that kneecap laterally, and you're going to have lateral tracking. Okay? So you're going to have a positive patellar tilt test. We'll go over that in lab tomorrow or Wednesday. Plus, you might also have pain on the medial side. Now, why would you have pain on the medial side? Think back to our palpation lab. What's on the medial side of the knee that kind of feels like you're rolling over a rubber band? If you were thinking to yourself plica, you would be correct. So you remember your plica tend to stabilize or keep that kneecap where it needs to be. With that kneecap now tracking laterally, okay, now you're having an issue where those plica are now becoming inflamed and mad. So again, you think that the knee is just a hinge joint, you are mistaken. There's lots and lots of different things that come into effect. Okay? So our femur landmarks, we've already talked about a greater position of these. I'm not going to go through them because I'm trying to save time, because the shorter the lecture, the easier it is to upload. So these we talked about last time. Adductor tubercle, where the adductor magnus attaches to, linea aspera, pectineal line, patellar surface. We didn't talk about the patellar surface. Patellar surface is located between the medial and lateral condyles and on the anterior side of the bone. Articulates with the posterior side of the surface of the patella, like we just talked about. Okay. Patellar surface. So tibial landmarks, we haven't, the only thing that we talked about before was the tibial tuberosity. Okay. We'll hit that again, but in a second. Your intracondylar eminence, that's the double pointed prominence on the proximal surface at midpoint, extends up into the intracondylar fossa. This is where our collaterals tend to originate. Okay, our medial condyle, proximal medial end, lateral condyle. Even though they are concave, they are still called condyles. I don't know why. Don't ask me silly questions. Okay, the plateau is in large proximal end, includes the medial and lateral condyles and the intracondylar presence. Oh, I already erased it. Okay, that's the tibial plateau, and you'll hear me talk about that. Tibial tuberosity is that large projection on the proximal end on the anterior surface in midline. Okay. Awesome thing about the fibula is that it does not include weight bearing. Okay, so that was it for the tibia. Not a lot going on. Ooh, I skipped over that. So the intracondylar eminence, your tibial plateau is this whole thing. Tibial tuberosity on the front. You have your crest, that's your shin bone that hurts a lot when you kick it on a truck hitch. Okay, and all the way down to your medial malleolus. We'll talk about that more when we talk about the ankle. All right, the fibula, lateral and smaller than the tibia, much smaller. It's not used for weight bearing, so it doesn't need to be as big. Okay, set a little bit posterior from the anterior surface, and it gives the leg its rounded circumferences. It is not included in the knee joint. It is the reason why it's there is it provides an attachment from these structures as well as ankle stabilizers. It's on the lateral side, forms the lateral malleolus, okay? But it is not really included in the knee joint because it doesn't articulate with the femur at all. Patella is a triangular sesamoid bone, largest sesamoid bone that we have in the human body, okay? Within the quadriceps muscle tendon. So some anatomy texts we'll say that the quadriceps tendon goes from the musculotendinous junction of the quadriceps to the patella, and then the patellar ligament goes from the patella down to the tibial tuberosity. Okay? Our book says quadriceps tendon for the whole thing. Okay? It has a broad superior border, a pointed distal portion, right? And that's what it looks like. It looks like a triangle. Has a inferior pole, a superior pole, and a medial and lateral. Okay? On the back side, it does have articular cartilage because it articulates with the femur. Why do we talk about the calcaneus? We talk about the calcaneus because it is the attachment site for the gastroc, or gastrocnemius muscle. With the gastroc is a two-joint muscle. It crosses the ankle and it also crosses the knee. Secondary knee flexion structure. So ligaments and structures, two main sets of ligaments we have are cruciates that cross. Okay, cruciate means cross on the inside of the knee, on the interior portion of the knee. And you have your collaterals that go on that run kind of on the parallel medial and lateral sides of the knee. We also have the medial and lateral meniscus. We have a popliteal space that includes a nerve artery vein. And our pes serene that kind of made its informal debut last week when talking about the hip. So lateral, if you're ever wanting to decide, is this what side is my lateral side? Always look for the fibula. Okay, always, always, always. If you're looking at x-rays, if you're looking at an MRI, if you're ever trying to kind of orient yourself to what you're looking at, always, always, always look for the fibula. Fibula is going to tell you medial lateral. So your lateral collateral ligament is kind of outside, and we'll talk about this in a little bit because that is has some interesting attributes from the medial collateral ligament. Okay. Your anterior and posterior cruciate ligaments, they are so named for where they attach on the tibial plateau. Your anterior cruciate ligament is located on the kind of inserts onto the anterior tibial plateau, and your posterior cruciate ligament attaches on the posterior side of the tibial plateau. Okay? They then cross or go up and forward. So your ACL goes from your anterior tibial plateau to your posterior femur, and your posterior cruciate ligament goes from your posterior tibial plateau to your anterior femur. And those are important in just a second. So, and we're talking about now. So your ACL, also known as your anterior cruciate ligament, attaches to what we just talked about. Okay. Keeps the femur from being displaced posteriorly on the tibia. It also keeps the tibia from being displaced anteriorly on the femur. So let me redraw this so that we can get our head straight while we talk about it. Again, I'm not sure if this is in frame. I hope it is. Let's back it up so I get a wider angle. Okay. All right. So we're going to draw it in about 15 degrees of flexion. Tibial plateau. We'll draw our ACL first. ACL. That is, I hope that's showing up. Probably not. Marshall was drawing with it and left the cap off. Okay. And our PCL, posterior cruciate ligament, comes up like that. Let me go get a better color. Hold on. Here. Oh, look at that. There we go. Okay, so our ACL. Okay, so our ACL prevents the femur from being displaced posteriorly, So you have the femur goes posterior, that's not going to let it, right? Or the tibial from going anterior, that's not going to let it, okay? Awesome thing about the knee is that our orthopedic tests that we'll talk about are very, very specific and sensitive to ligamentous injuries. Okay? Your Lockman's test, which tests the integrity of the ACL, is just as good as identifying an ACL rupture as an MRI is. Very cool. We'll talk about that. We'll hit on that. Okay? ACL prevents posterior moving on femur moving on the tibia, or an anterior tibia or an anterior force on the femur. Okay. Another interesting note is that this is tight during extension to prevent hyperextension. So if you have an injury, okay, or if you have a mechanism of injury where you are forced into hyperextension, okay, that can be a mechanism of injury for an ACL tear. A couple of different mechanisms of injury. We'll talk about that when we talk about pathology. And this gives a good representation. Your posterior cruciate ligament attaches on the posterior tibia in the intercondylar area, runs superior and anterior on the medial side, on the medial side of the ACL, and attaches to the anterior femur. It keeps the femur from displacing anteriorly, like our picture describes. Keeps the femur from going anterior on the tibia, or it keeps the tibia from going posterior on the tibia, or on the femur. Okay? Mechanism of injury for your PCL isn't quite so kind of vast. Pretty much PCL, knee bent, and you're in a front end accident. You're going to pop your PCL. And this tightens during flexion. Much less frequent injury than your ACL. ACL, if you are on a high school sports team, college sports team, even at college intramurals, adult rec leagues, okay, people pop their ACLs like it's going out of style. It is crazy how many people tear their ACLs. I've only done one, and I was told when I tore my one that popping the other one was almost a certainty. There's like a 75% likelihood that sometime in your life you're going to pop the other one. I have made it, how old was I? 17? I can't do the math right now. How old am I now? 33? Yeah, I don't know. I made it like 17 years without it. Without popping it. Medial and lateral collateral ligaments. Okay? These are best viewed from the frontal side. So our tibial collateral ligament, also known as your tibial collateral ligament, okay, is this flat and it's a broad ligament. It's very wide. Okay? Attaches to the medial condyles of the femur and tibia, and it provides that medial stability. Prevents excessive motion as if there's a blow to the lateral side of the knee. Okay, also known as a valgus force. All right. I'm in a drawing mood right now. So if this is our knee, we're going to draw the femur and our tibial plateau with our intercondylar notch. Draw our fibula to identify if it's lateral or medial. Okay. So, as our picture before described, this thing is, pardon me, okay, broad, flat, provides medial stability, okay? That prevents excessive motion if there's a blow to the lateral side of the knee. What's that blow going to be called? What kind of force? We've gone over this before, where you have a force coming in from the lateral side, and it's going to kind of buckle it. It's going to go boom. What's that force called? Do-do-do-do-do-do-do-do. If you are thinking a valgus force, you would be correct. Okay? You can see how that is going to protect or not ward off, but protect's the best word, the knee from a valgus force. Okay? This can be a physical force, or this could be going back to our picture, okay? Or this can be someone with poor knee mechanics, and when they jump or they load it, okay, that could be a valgus force as well. You're still going to have a force coming in from the lateral side. This is tight during extension and on slack during flexion. Lots of good things from being on slack. Okay? Lots of bad things happen when things are tight. So we know two structures that are tight during extension. What are they? Our ACL and our MCL. Let's keep those two things in the back of our head. ACL and MCL are related because they are both tight during extension. Okay? Come back. We're going to come back to it. And you can see how the other awesome or interesting aspect is how the MCL kind of goes along and probably attaches to all these different structures. It's attached somewhat to the medial meniscus. Okay, so normally if you have an MCL tear, you also have a medial meniscus tear. Hi, how are you? I'm Dan. Nice to meet you. Our lateral collateral ligament is also known as our fibular collateral ligament because it attaches to the fibula. Round and cord-like. Okay. Other one, MCL, broad flat. LCL, round, cord-like. Okay. Attaches to the lateral condi of the femur and runs down to the head of the fibula. It does not attach to the lateral meniscus. Unlike our MCL, that attaches to the medial condi of the femur. Okay. Protects the joint from stresses to the medial side of the knee. Okay, so let's take our handy dandy eraser. I'm going to throw in our LCL. We'll do this in red. I don't like to do things in red. So it protects against forces on the inside of the knee. Okay, what are those forces called? Those forces are called varus stresses. VARUS. It is a quite strong ligament, and again, not one of our commonly injured. It provides stability to the lateral side of the knee, tightens during extension, so it also is tightened during extension and slack during flexion. And then clinical application 19.2 looks at different lateral forces on the knee, much like we're talking about right now. Okay. All right, moving on to the meniscus. Our meniscus, located on the superior surface of the tibia, and they are two half-moon wedge-shaped fibrocartilage discs. All right, so we've talked about lots of peripheral joints so far, and a good handful of them have some type of fibrocartilaginous disc. Okay? You have a labrum in your shoulder and in your hip. You also have a fibrocartilaginous disc, where between the articulation between your ulna and your proximal row of carpals. Okay, you have a fibrocartilaginous disc in your TMJ. Okay. So the fibrocartilaginous discs are designed to absorb shock and also increase that surface area. Let's draw that one more time. Really in the mood to draw. Look at me go. So this is a frontal view. So let's draw. I should have just erased because that was a decent drawing of femur. Draw femur in. Okay. Now, if these two joint surfaces came together, right, where would the contact be? It would probably just be here, and here. Would that get degenerated fast? Yes. Okay. I would draw these arrows. I would draw these arrows big because that would signify that there was a lot of force going through at those individual spots. Okay. Now let's erase those. Tidy up our drawing a little bit. And let's draw our meniscus in. Ooh, that's a bad drawing. Another bad drawing. Too much space. Some aspects over here. Okay. And what does that do to the force? Okay. It just like with the glenohumeral labrum, it spreads that force out all along that surface. Okay. So now we don't have one big one in one area. Now we have lots of smaller ones to help spread out that force. Kind of give our articular cartilage a standing chance to last into our 60s. Not going to happen a lot with the knee. Quote unquote, deepen the joint surface, whatever. Medial is torn more frequently, okay? And that has to do with the locking mechanism. So this is your lateral meniscus and your medial meniscus. Okay, so your lateral meniscus, you can kind of, this picture kind of shows how kind of much less deep that one is. So that medial meniscus, and usually from what I've seen clinically, the posterior medial side of that medial meniscus, posterior PMM, you'll see PMM tear a lot on an orthopedic script pad. Okay, posterior medial meniscus, because that medial condyle has shifted. Okay? This one usually doesn't get torn a lot because it's made to shift. Okay? Because it's made for that screw home mechanism. This one isn't made to shift. And anytime you get a shift, you're going to tear that medial. Okay? Enfields. Soft tissue approximation for knee flexion. Soft tissue stretch or a firm enfield is going to be knee extension. Okay? Ligamentous restrictions. You have bursa all up underneath and around your knee. Okay? You have a suprapatellar bursa. You have a infrapatellar bursa. Okay? You have all kind of bursa around your sartorius gracilis semitendinosus. What's that called? Your pes serene. Okay? All kinds of bursa. Biggest one that we're worried about is usually that one. Okay? There's 13 of them in the knee joint. Needed to almost vertical line of pull of the many tendons of the knee. So that suprapatellar one is going to be the one that we're usually worried about. Our popliteal space is the area behind the knee. Contains the tibial and common peroneal nerves and popliteal artery and vein. That, my friends, the popliteal space, or just proximal to the popliteal space, is where the sciatic nerve, the big, almost nickel-sized nerve running down the back of your leg, okay, where it splits into the tibial and peroneal nerves. Diamond-shaped. The superior medial border is your semitendinosus, semimembrananeous. Superior lateral border is your biceps femoris, and your inferior border is the medial and lateral heads of the gastroc. You'll see it. It's coming up on your screen, and there it is. Lateral border is your biceps femoris. Medial superior border is your semimembrananeous. Okay? And your inferior borders are going to be the medial and lateral heads of your gracil or your gastroc. Okay. You can see how it just split just up there from your sciatic to your tibial nerve. That's going to run down here. Okay, be part of Tom, Dick, and Harry as it goes around your medial condyle. Okay. And then your common peroneal nerve as it wraps around your fibular head and goes down and hits your tibialis anterior and your peroneus longus and brevis. We are not there yet. Those are with the ankle. We will talk about those in a little while. Your pes anserine made its informal debut last week, okay, but its formal debut this week. Made up of sartorius, gracilis, and our semitendinosus. Circle the T and write segrace before T. Sartorius, gracilis, and semitendinosus. Okay. Each has a different proximal attachment, as you know. Sartorius wraps up and goes to your ASIS, gracilis all the way up to your pubic bone, and your semitendinosus all the way up to your ischial tuberosity. Okay. Joined together to attach distally on the anterior medial surface of the proximal tibia. Boom. This, my friends, is a very common spot to be irritated, PO'd, and just painful. And people will know it. People will be, you'll ask someone, where does it hurt? And they point to here. You know that that is your pes anserine. All right, muscles, quads, 4 quadriceps. Your rectus femoris crosses the hip joint. Everything else is a one joint muscle. Your vastus lateralis, your vastus medius, and your vastus intermedius. Your vastus intermedius is the most deep. It's underneath your rectus femoris. You have your hamstrings that we've talked about already. There's 3 of them. 4 if you want to get picky with your biceps femoris. Your semimembranosus, your semitendinosus, and your biceps femoris. You could write long head and short head over here to the side if you want to. Okay. Your gastrocnemius, its best friend will be the soleus. The soleus is not talked about today because the soleus only crosses the ankle joint. We've already been through the rectus, the 3 that we haven't talked about, your vastus lateralis. Okay, so that runs on the lateral side. Same action, knee extension. Now, when we get to our vastus medialis, this little sucker has a little bit of a controversial role between the worlds. Okay. The vastus medialis, you can see how there's oblique fibers. Okay, it is thought by some orthopedic doctors. I'm not saying that condescendingly. I don't mean to. They feel that when you have lateral tracking of the patella that we've talked about, right? We talked about the vertical or the kind of the greater the Q angle, the more lateral pull the quadriceps are going to have on the patella, and it's going to have lateral tracking. Okay? Some orthopedists believe that with a stronger vastus medialis, okay, it's going to be able to correct that patellar pull, be able to pull, kind of correct it, and get it more sliding in that intertrochanteric groove. Okay? I'm not saying that they're wrong, but I just don't agree. And we'll talk about in lab why that is not true. Okay? You don't have the vastus medialis that have a different nerve. It's all being hit by the femoral nerve. Okay, so it's all going to fire at once. You can't selectively increase the strength of your vastus medialis. Okay, or maybe you can. Do a research project on it. Do your research project for 120 on vastus medialis firing. Okay? Change my mind. I don't know if you can. I don't know if anybody can. And you can. Present me with enough evidence, I'll change my mind. Okay? But, and we'll talk about the treatment protocols, usually probably in 140. We'll talk about it in 140, what exercises to do for that patellofemoral pain syndrome. Okay, because it doesn't come from the quads. Nope. You got to control the valgus, or the valgus moment. You have to control the femur, and that's not done with the quads. That's done with your butt. That's done with your glutes. And so we'll talk about that more. And your vastus intermedius, which is the deep one all the way down. Okay. Again, they all do the knee extension. Seriously, nothing really changes except that origin. Vastus lateralis wraps around from your linea aspera. Okay. Vastus medialis wraps medially around to your linea aspera, and then your intermedius is from your anterior side. Semimembranous and tendinosis, you guys are already aware of and how to palpate them. We'll do it again. Biceps femoris, you have a long head, short head. Long head is a 2-joint muscle. Short head is your 1-joint muscle. Semimembranous and tendinosis have the same origin. Biceps femoris, long and short head have the same insertion. Fun fact. Oh, we do talk about the popliteus. Good. Okay, so popliteus, lateral condyle of the femur. This is the posterior view, and it goes to the posterior medial condyle of the tibia. Okay. Initiates knee flexion because we unlock the knee. You could write off to the side. Unlocks the knee. Indiana Jones and the Temple of Doom was on yesterday. So it unlocks the temple. Unlocks the knee. Tibial nerve. Gastroc, 2-joint muscle. Medial head, lateral head, goes up to the femur and down to the calcaneus. Does ankle plantar flexion mainly, but also assists in knee flexion. That's why when you're doing anything, if you're doing if you're a gym person and you go and you do leg curls and you sometimes get a cramp in your calf, and you're like, why am I getting a cramp in my calf? I'm working on my hams, trying to get my hamstrings dialed in. Okay? It's because it's helping. Your gastroc is helping with knee flexion. I feel like I'm getting more comfortable doing this, which is a bad thing, probably. So I'll let you guys figure that one out. It's just reading it. I don't think I need to read it for you. We've talked about a lot of it. Okay, summary of muscle actions. Extension is your quadriceps, flexion, hamstrings, popliteus, and gastroc. Levels. All right. Going into common knee pathologies. See, we're doing well. We're doing good with time. Are we doing good with time? I don't know. Genital valgum, genital verum, val, ver. Guess what it is? Valgus and varus. And recurvatum, knee hyperextension. Patellotendinitis, Osgood Slaughters. We have popliteal cyst or Baker cyst. Patellofemoral pain syndrome. We're going to hit this a couple of times in 120 and 140. You'll get a 1-2 punch of that. Kind of what is it, what's going on, and how do we fix it? Ooh, I didn't know I had those down there. Okay. Chondromalacia. You'll see that fairly common. Okay. Prepatellar bursitis. Terrible triad. Hi, how are you? My name's Dan. Okay. And a miserable malalignment syndrome. Genital valgum, also known as knock-kneed. Look at that. That, my friends, is rough potatoes. Okay? Where distal segments of the ankles are positioned more laterally than normal. Okay? Because you have issues here. Knees tend to touch while your ankles are apart. That's pretty rough. Okay? Genital varus is bow legs. Miss Jen in lab is going to say, "There is my horse." I can guarantee you that she will say this. So if you watch this before lab in the morning, Jen, I bet you $5, Jen will say, "There is my horse." Okay? That's an alignment problem where the distal segments are positioned more medially and the ankles tend to touch while knees are apart. Okay? Seen with coxa valgus. Okay? So with coxa valgus, remember that angle is going to be less. So that femur is going to be coming out this way, and then it's going to come back in. Fun question. With valgus and varus, what side of the knee is receiving more compression? Or, to put a more functional term, what side of the knee is going to wear out first? Since we're on the slide, let's talk about varus. All right. So with varus, genuine varus, if I have femur, tibia, lateral, medial. Okay, what side is going to receive the most compression? Right, remember we're in weight bearing, so we have that ground reaction force going straight up. Okay? If you were to say medial side, you would be correct. Okay, you have a compression on your medial side, and you have a gapping on your lateral side. Genuvarum, medial compression, lateral gapping. Okay? That side's going to wear out first. If we flip that over, we have that ground reaction force going up. Now what side for valgus? Valgum. Now what side's going to have the compression forces? Okay. You have your lateral side is going to have compression forces, and your medial side is going to have distraction. Sorry, I'm getting fancy with my pens. Your lateral side of your knee is going to wear out faster. Okay. Hopefully that makes sense. Now, we'll wait. Probably felt like you were looking at a 5-year-old with a FaceTime. Okay. So genu recurvatum, okay, that is excessive knee hyperextension, where its range of motion goes beyond 0 degrees of extension. That's like 20 degrees. That's rough. Patellotendinitis, also called jumper's knee. Okay? Tenderness at the patellar tendon results from overuse or sudden impact overloading associated with jumping. Okay? So if you have someone in the tall tale sign is going to be inferior pole of the patella. You throw your thumb up in there and they don't like it. Okay? Because it's inflamed. It's an itis. It's inflammation. Common in basketball players, high jumpers, and hurdlers. Anybody who does a lot of jumping or a lot of running on hard surfaces are prone to getting this. Okay? To combat that, we talked about those wraps for people with lateral and medial epicondylitis, which kind of creates a alternative attachment point for those common tendons. Okay? Those knee straps, that's what those do. Okay, they take the pressure off of the junction between your tendon or your ligament and your patella, and they create a secondary attachment point. It allows things to rest and calm down a little bit. Okay? Josh, get ready. I'm going to call on you, sir, when we talk about this. Osgood-Slaughter's disease, common overuse injury among adolescents. Okay? Involves traction type epiphysis on the tibial tuberosity of the growing bone, where the patellar tendon attaches. Okay, can get pretty bad, can get pretty pointed. Okay, look at that. That's a full-on separation of the periosteum. Now, will they go in and do surgery on that? Probably not. They'll probably just have them rest, ice, and wait for that to recalcify. Some people, especially usually tall individuals, what usually happens of this is when, especially adolescent males or very really tall adolescent females, when they hit their growth spurt, okay, their bones are lengthening at a magnificent rate. And their ligaments and tendons and their muscles can't keep up. Okay, that collagen can't get laid down fast enough. So what's going to happen is when those tissues are loaded, they're going to become extremely tight. And they're going to pull that periosteum off. The popliteal cyst, also called a Baker's cyst, or a synovial hernia or bursitis in the back of the knee through the popliteal fossa. Increase of fluid back there. Patellofemoral pain syndrome, very common, diffuse anterior knee pain. Results of alignment factors, increased Q angle, patella alta. Patella alta is where the patella rides high. Patella baja is when the patella rides low. Patella alta is where the can contribute to patellofemoral pain syndrome. Okay? And quad tightness, weakness or tightness in our lateral hip rotator weakness, and we will talk about those things. We will talk about these things. We'll talk about this. Is one of my favorite things to talk about because it just makes sense. We'll talk about it. Your chondromalacia patella is softening and degeneration of the cartilage on the posterior patella. Okay, so usually your patellofemoral pain comes first. You have pain. Okay, if it keeps going long enough, you're gonna end up with some damage, some degeneration. Abnormal tracking within the groove causes articulated cartilage to become inflamed and really pedoed. Okay, and it looks like a little frayed edge on the backside of your patella. Your peripatellar bursitis, housemaid's knee, sounds bad because it's a lot of people who kneel. A lot of people who do hardwood flooring, a lot of people who lay carpet, okay, they get a peripatellar bursitis because they're always kind of all kneeling on a hard surface. Or a result of repeated direct blows or string stresses on the knee. Look at how swollen that bursa is. All right, terrible triad, also known as unhappy triad. You'll hear more terrible triad. Knee injury caused by a single blow to the knee. It involves the ACL, MCL, and medial meniscus. Ka-chink. Okay. Usually, the mechanism of injury can be a physical blow, or it can be deceleration, tibial internal rotation, and usually slippage. Okay, but it's where you have all three: ACL, MCL, and medial meniscus. Hi, I'm Dan. I had a terrible try. Okay. ACL, sprain, strain, rupture, whatever you want to say. Not strain because that's a muscular torn term. Okay. ACL sprain or rupture, most common knee injury, especially among adolescents. Females higher than males. Athletes in high demand sports are at greater risk, like soccer, football, basketball. Surgery, severe, or return to previous activity level. You can go on being fine. One of the part-time anatomy instructors is just tore his ACL last year doing CrossFit. Oh, CrossFit. Okay. But he's 50-something. He elected to not have surgery because his outcome wouldn't have been that great. And he can still paddleboard. He can still play sports. He just has to wear a brace. Okay. Causes of change directions rapidly, stopping, slowing down while running, landing from a jump incorrectly, usually in that fully extended position, that closed pack position, and in a direct or contact collision. Okay. There's an intact ACL. Look at the fibers rolling. No more fibers. Complete ruptured ACL. Oh, look, there's a ball. Oh no, my ACL is gone. MCL sprain, injured more often than your LCL, just because it is a more common mechanism of injury. Okay, direct contact to the outside knee, creating a valgus stress. And on the MRI, you see the deficiencies in it. In our miserable malalignment syndrome, is an alignment problem in the lower extremity. Involves increased anteversion of the femoral head, okay, associated with genu valgus, increased tibial torsion, and pronator flat feet. So look at that. Okay, so if you look at the patella signifies that that femur is anteriorly rotated or internally rotated, right? We talked about anteversion now being that is going to cause a internal rotation moment at the hip. Okay? And that's what that is showing there. We will watch these videos in lab tomorrow and we'll talk about them in the morning. So you can read the points to remember on your own. As we are going through this, we have the ankle and then we have gait and then we really don't have too much left. Okay? So keep on keeping on and I'll see you tomorrow in lab. Oh, there's still more. There we go. All right.